Good now. He comes to us today from Brown University. He did his undergraduate and medical school training at University of Tennessee, and then did his residency at Brown, along with the infamous super chief year, followed by total joint fellowship at Brown, and now he's on faculty, on staff there, and he is also the co-director of the total joint fellowship at Brown. So even though we were not at Brown at the same time, Eric and I have been able to collaborate on some work together. We've exchanged cases, and it's been a really good friendship that we've had over the last several years. So it's really great that he's here today, and he's going to talk to us about periprosthetic fractures in direct anterior total hip. So Eric, thanks for coming here today.
Yeah, thanks, Steve. Really excited to be here. I got in a day early so I could spend some time with Steve in the OR yesterday. I got to see him do several direct anterior hips, and I got to tell you that I took a ton out of it. I try to do that every year. Go see an expert surgeon in anterior hip replacement. Steve Kairos is definitely an expert surgeon. You guys are lucky to get to learn from him from the approach. I think he's got a ton to offer, and there's so many different things that I kind of picked up just from that day in the operating room, the OR efficiencies that we're going to bring back to Brown. So it's really a privilege to spend some time and then to come and give these lectures, and looking forward to the cases after as well. Now, Steve and I didn't cross paths. The closest we came to crossing paths at Brown was at graduation. I was an incoming intern and he was leaving. He was a trauma fellow. We were in this large, I guess, art gallery at the RISD Museum. And while Steve is kind of a legend at Brown, and so I was sitting in the back, and that infamous kind of cackle laugh was coming from the front continuously. I was like, who is that guy? And I was like, oh, that's Steve Kairos. And so certainly, that was kind of our first crossing, I guess, in some ways, but we've developed a great relationship, and there's kind of been this Brown Rutgers connection. Matt McDonald is one of the spine attendings here, and certainly was a great mentor to me as well. And so it's a lot of fun to be back. We've been able, due to COVID, to do an indications conference with our fellow, and Steve has joined, and some of the residents from Rutgers have joined as well. And it's been really great to get everyone's input from other places as well for those cases. So I'm going to talk about avoiding periprosthetic femoral fractures in the direct anterior approach. This is something that all of us have experienced adopting the anterior approach. And I kind of want to glean some knowledge of what I've learned through some of the trials and tribulations, so you guys don't have to go through it. And if you do go through it, you know what to do when it happens, because it will happen at some point. So I have no disclosures. The only disclosure I have is that there's many ways to do a hip replacement. I'm not here to tell you that one's better than the other. I do anterior, anterolateral, and posterior approach hip replacements. I do anterior, anterolateral, and posterior approach for vision hip replacements. The majority of my primaries are anterior hips, and is one of the reasons I went into arthroplasty for a lot of reasons. But I think each approach has its advantages and disadvantages, and picking those for those patients, I do them all. So why is this so popular? Well, it's a true intramuscular internervous plane for hip replacements, and many claim a quick recovery and better gait mechanics and reduced risk of dislocation. All those, I think, are true. I think in the long run, if you do a hip replacement right, the patient's going to do just as well with any approach. So I'm not here to tell you one is better, but it has been marketed, especially by industry. And as a result, patients are asking for it. So patients will seek you out if you're doing the anterior approach. So I guess the first question is, does the anterior approach have an increased risk of femoral complications? Who in the audience thinks that's true? No one? No? All right, well, it does. It does. It has increased risk of femoral complications. Steve, Dr. Kairos, Dr. Harwood may not have those complications, so maybe you guys haven't seen it, but certainly out in the community, we're seeing referrals from periprosthetic fractures or complications from adopting the anterior approach. That may be just learning curve. I think there's probably a little more to it. And the reason anterior approach has increased risk of femoral complications, and it's maybe the disadvantage of anterior approaches, you don't have a direct line to the femur when you're accessing the femur, approaching the femur. You're either dropping down and in or coming from the side. And so if you don't know what you're doing or where you're going, you're going to run into problems. And so the first X-ray is a periprosthetic fracture a couple days after an anterior hip. That's actually my case. This was a 73-year-old lady who was pretty healthy, who had some early Alzheimer's dementia. She forgot she had hip replacement. She was feeling well and had a fall a couple days after and suffered this fracture. And the second one is femoral perforation out the back. Typically, these are kind of posterior and medial. They're in usually large obese patients with hip flexion contractures. These are difficult cases to access the femoral canal. Talk a little bit about how to avoid both of these type of fractures and how to treat these fractures if they happen to you. We'll talk a little bit about intraoperative fractures and early periprosthetic fractures within the first 90 days. I kind of grouped them together because they really are similar. Some early periprosthetic fractures maybe are a missed calcar fracture. Some are fractures for other reasons due to maybe lack of implant stability and rotational issues. And then obviously intraoperative fractures can happen just approaching the femur. So we'll go over the risk factors for periprosthetic femur fractures, implant evolution for direct anterior approach, and selection of these implants. We'll identify difficult femoral exposures. I kind of hinted at a couple here in the slide previously. Then I'll go over my exposure tips and tricks and kind of how to stay out of trouble with the anterior approach. And then we'll talk about what happens when you have one of those fractures, how to treat them and triage them, and then a few take-home points and hopefully some questions. So regardless of approach, anterior, posterior, anterolateral approach, risk factors for periprosthetic femur fractures are poor bone quality. So anyone with metabolic bone disease, osteoporosis. In general, these are female patients that are elderly, over 65. Total hip or femoral neck fracture. The idea is if you fell and broke your hip once, you can fall and break your hip again. So they're definitely at increased risk. Morbid obesity, patients with dementia or risk of falls. And then using uncemented stems. Uncemented stems is a risk factor for periprosthetic fracture. They certainly have a higher rate of fracture than cemented stems. So regardless of approach, these are kind of the things to look out for when you're assessing patients for hip replacement. And pre-op planning is really essential to stay out of trouble, to know what the end goal is. And so not one implant fits all, and sometimes you need to adapt to the morphology of the femur, whether it's a door A bone, which is a tight femoral canal with thick cortices, or a door C bone, which is thin cortices, kind of stovepipe femur. You have to use different stems for different femoral morphology as well as bone quality. Whether there's previous hardware, planning how are you going to take that out, where is the hardware, how far do you need to bypass that hardware may dictate what stem you need. And then, you may need large or small sizes, varus or valgus necks, differences in offset, eye offset, et cetera. And so, the risk of the anterior approach is femoral exposure. The incidence of intraoperative femur fracture has been reported between 0.8 and 7%. I think that's pretty high. A lot of that's coming from some learning curve articles, which I'll get to here shortly. But the reason is you're not getting that inline, direct inline view of the femur like you would on a posterior approach. And so there's many patient factors that make it exposure difficult in total hip arthroplasty. We'll go over those here next. This is called a Panda Sling, if anyone's interested. The website to buy it is right below. You can get it for your patients or yourself, whichever you prefer. But it is a real thing. I'm not sure that guy is real, but the sling is real. So patient factors, what makes exposure difficult in the anterior approach? So when I'm looking at an AP pelvis, some of the things I'm looking at is how wide is their iliac wing? So the AP X-ray labeled A shows a narrow iliac wing. And what you can see is there's a big space between the ASIS and the greater trochanter. Okay, that's your working distance. That's where the femur is going to come up when you're getting your exposure. That's going to allow you to lateralize the femur so you can get direct access to the femur. On X-ray B, what you can see is a wide iliac wing, okay? I call that the Mickey Mouse pelvis. If the pelvis looks like a Mickey Mouse, that means you're going to have a hard time gaining direct access to the femur. The reason is the wings are pushing out and you're trying to access the femur here. So you're really going to have to really lateralize the femur, may have to use double offset broaches that are going to lateralize you to get around the iliac wing, or use some other tricks that I'll talk about earlier. But you need to recognize that not all hips are the same and not all pelvises are the same. And this wide iliac wing makes exposure incredibly difficult, especially in someone who's morbidly obese, especially in someone with a short varus neck. When you combine one or two of these difficult exposures, it's going to be a real problem to access the femur, and that's when complications happen. So those other factors, short varus neck, the problem is the rotators are very tight. It's very difficult to lateralize the femur to get direct access to the femur. A large firm abdomen, I'm not talking about the soft kind of jello stomachs. I'm talking about the big medicine ball round bellies that really don't have any movement. Again, that's going to act like an iliac wing and really push you lateral, make it difficult to access the femur. Really large panduses can do the same. And then hip flexion contractors act a little differently. To access the femur, when you're working with Dr. Harwood or Dr. Kairos, whether they're on a regular table or a Hanna table, what you're doing is you're extending the leg and you're adducting the leg. And what happens, what you're trying to do is bring the femur up like this. With a hip flexion contracture, their femur stays horizontal. So you really need to do large releases on the femur. Oftentimes you need to take the psoas tendon to get that femur to elevate and extend. Otherwise, you're going to go out the back like that X-ray I showed earlier. And then prior hip fusions are just difficult just because they're very stiff hips, require extensive release prior to even doing the acetabulum, let alone the femur. And so there's certainly a learning curve. I think knowing which patients to avoid early on is important. These are 3 articles that talk about the anterior approach learning curve. The first one's by John Masonis at Ortho Carolina. It's his first 300 consecutive patients that he looked at, and he had fractures in the first 62. After that, he really didn't have any major complications. So that was probably on the shorter end of the learning curve compared to the other studies that have been performed. And that's taking all comers. So those are consecutive cases. And then Jewett looked at 800 cases, and he really, within the first 100 were the majority of his fractures, and the majority of the fractures were greater trochanteric fractures. There was 1 femoral perforation, but he had fractures up until about 400 cases, but really it was, that was like 1 here or there. It was really the first 100. Hartford reported on he reported on 500 cases, and it was the first 100 cases. He had a 7% rate of intraoperative femur fracture. And then after about 300 to 400, it was 0. He had 1 here or there. So it's probably about 100 cases is a learning curve for the anterior approach. This is probably shorter if you learned it in residency, if you learned the approach fellowship, and then you're going out into practice. There are no studies. I'm actually interested in looking at our previous fellows to see how they're doing in their first couple hundred cases. Are they having these same complications at the same rate? My guess is it's probably a little less. But I know coming out into practice, there were certainly some struggles and some learning on my own, even after fellowship. So what are some of the risk factors for a direct anterior approach? A few studies, Hartford looked at this as well. And basically it's the same risk factors that it is for any approach I talked about earlier. Female gender, morbidly obese, and small implant size are probably the most important. They had about a 4.6% fracture rate. Keith Barron and Adolph Lombardi and his team looked at their 3,000 cases. They found a much lower fracture rate. They were out of the learning curve. They had been doing this for a long time. It was about 0.9. So they were using strictly cementless implants, mostly ML tapers. That fits with the literature and other approaches. Posterior approach for periprosthetic femur fractures about 0.9%. So with time, you can get better, but still the risk factors are elderly and female. And I think you're going to kind of see a theme throughout this entire talk that the older female patients really are the highest risk for periprosthetic femur fractures, and really maybe we should be doing something different for these patients. What about standard versus traction table? So at Brown, we had a couple surgeons, so we got exposure to both, and we looked at both standard and traction table. We looked at almost 500 cases and found the intraoperative femur fracture rate to be about 2.46%. And there was no difference between the table, fracture table, and the regular table as far as fractures. I don't think it makes a difference. I think, you know, with a fracture table, you can get in a little more trouble if you're trying to force the femur up and you're using a Hannah hook. I know Dr. Karras doesn't use the Hannah hook. You guys trained, but most people do. And if you're pulling up on the femur and haven't done adequate releases, you certainly can cause a greater trochanteric fracture that way. And then this is a systematic review looking at all the studies and direct anterior approach with a flat table and traction table. Basically, they found the same thing. So it's really how you're trained and what you're comfortable with. And do you have someone to operate the traction table? I do the majority of my cases on a handed table. I do some on a regular table. If there's not staff that's comfortable running a traction table, it's my feeling that I can train anyone to do traction table, and it doesn't have to be a big thing. There's only a few maneuvers you need to do, and nothing is forced. And they know when they're in my operating room that we don't force anything. Everything should go very easy. And if you're feeling resistance, just relay it to me, and we'll kind of reassess. And that's, I think, worked great for us. The only time you get in trouble is when someone else who doesn't have that tactile feel is trying to reduce a hip against the iliac wing or acetabulum. You don't have the length. That could be a problem. That's a force thing. And so as long as you communicate well, I don't think that'd be an issue. And these studies have come out and show that. So all these studies are similar. What are their similarities? They were performed in the United States. They were mostly early adopters of direct anterior approach, and they exclusively use uncemented stems. Even up until about 5-6 years ago, there really wasn't a dedicated implant for anterior approach. It was all using uncemented implants that were designed really with other approaches in mind, mostly posterior approach, minimally invasive posterior approach, or anterolateral approach. And so industry kind of had a catch up to do over the past 10 years to design. They designed the instrumentation, but ultimately to design an implant specific for direct anterior approach. So we're making do with what we had. And so, this is an example I'm using DePuy, but every company is going this route. And this is the kind of thought process of we need a different stem if we're going to do uncemented implants for a direct anterior approach. So figure A is a summit stem. It's similar. It's like a synergy. I think you guys use Smith and Nephew. This is a Riemann broach stem. It's a long stem. It's a dual taper or fit and fill proximally. And to put this in, you need a direct line to the femoral canal. You use long reamers, and then you use broaches. So a Riemann broach system is definitely, you can do an anterior approach, definitely easier to do in a posterior approach, and this was really designed with a posterior approach in mind. Implant B is, this is a trilock. It's a ML taper, so it's thick medial to lateral and very thin anterior to posterior. It's a wedge, single wedge taper stem. There's many similarities like a taper lock in Anthology, Smith and Nephew. And so this kind of got really popular when everyone was trying to do minimally invasive surgery, trying to limit their incisions to 10, 12 centimeters. It's a bone preserving stem. So the idea was it'd be easy to take out, easy to do revisions. But I'll explain here shortly why I think that's not a good stem to use in the anterior approach, and puts patients at a higher risk of a fracture if you're going to use uncemented stem. And the last stem is kind of the melding of the two, is kind of evolution. It's a fit and fill stem. This is the Actus, but there's DJO has a stem that's similar. Stryker's coming out with a similar stem. All implant companies are really coming out with a really similar stem to this. And I'll go over the characteristics of the stem, why this has been better for the anterior approach for uncemented stems, and how it was designed. So a little bit about the taper wedge stem. So there's a couple studies that have looked at this indirect anterior approach and found a higher fracture rate, especially with shorter taper wedge stems. They can either act like a log splitter or lose rotational control. And what kind of happens is, so this is a figure of the femur. You can see the greater trochanter, and I've labeled medial and lateral, so you can see the taper wedge stem is bigger medial lateral, and it's very thin anterior to posterior. And what happens is when you're broaching, especially with like a double offset broach, you're trying to get around the iliac wing, is that is going to rotate and you're going to lose anterior metaphyseal bone. So what happens is you really end up relying on the medial lateral fit of the stem. In poor bone, you can get significant rotational forces just ambulating. So one, you have a risk of subsidence. Two, you have a risk of rotational forces. And actually, most periprosthetic fractures are probably a combination of subsidence and some rotation. And as a result, you're going to get a fracture. So again, you don't have a straight line to the femur, iliac wing, or a large abdomen is pushing you out. You're using a double offset broach. You don't have full control of going straight in, straight out, and you're losing some of that anterior metaphyseal bone. So ML taper stems are going to have a higher fracture rate in the anterior approach because of that. And for that reason, I stay away from them. Prefer this like fit and fill stem from really any company. And the reason is you can see if you have something that's larger anterior to posterior, it's gonna fill that gap. That white is the gap. So it's going to fill that gap and give you more rotational control. So one benefit is the dual taper fit and fill. The other benefit is the rounded shoulder. So a lot of these ML tapers actually have a square shoulder. So you're trying to get lateral, you're dropping down and in. What happens is you can get lateral wall blowout or greater trochanteric fractures because how broad the proximal lateral portion of the stem is. So this has a rounded shoulder, and what it's made to do is basically drop down and in rather than going straight on the femur. They have a decreased distal thickness, so they don't pot, and then a rounded distal tip. And the advantage of the rounded distal tip is it's going to kind of ride the posterior cortex and prevent perforation. And then the final, not all stems have this, but this one tends to have a collar. So, what about the collar? So I put this in and told my wife, I got this great picture of Poly D with a pop collar. And she told me, well, you're dating yourself. No one's going to know who Poly D is. I told her, well, it's Jersey. They're definitely going to know who Poly D is. So he's also from Johnson, Rhode Island. So again, we got the Rutgers Brown connection with Poly D. And then the little guy, right? And then she reminded me that my son, who's 3, had his preschool picture, and he's rocking the same polo as Poly D. So I had to put that in there. But what about the collar? So, is a collar a good idea on a cementless implant? What do you guys think? All right. So the general dogma has been that, and a lot of the naysayers were that it's a bad idea. And I think a lot of that came from about 25 years ago. There was several uncemented collars that had a high failure rate. But it really wasn't the same thing. A lot of those were cobalt chrome stems with a lot of stiffness. They had a lot of loosening, a lot of thigh pain. So, these are titanium stems. So I think the collar got a bad rap in uncemented stems. And so the data is starting to come out to support using a Calcar collar for uncemented stems. Prior to this registry data, there were a couple of biomechanical studies looking at collared and non-collared implants in these labs. And what they found was it requires a greater force to cause subsidence, obviously, right? You got to push through a collar to push through the entire medial calcar, but also they have significantly more rotational control inherently because of the collar. So I think both of those things help prevent fracture, helps prevent leg length discrepancy, and gives early stability, which helps promote osseointegration. And so Lamb and his colleagues in England looked at England National Joint Registry. They compared uncemented implants with and without a collar, and they found that no collar implants had a 4.7 times higher risk of periprosthetic fracture. There's been a few other studies that have compared the Karai. So Karai is stem that's used a lot. It comes both in collared and uncollared form, so you can really compare groups. All these were retrospective, and then prospective or randomized. But they were used in like elderly age group greater than 80 for total hips and femoral neck fractures, and the collar really outperformed the non-collar in those groups. So I think the collar is a good idea. I use a collar on the majority of my uncemented implants. Because of that, it gives me extra peace of mind, and I think helps prevent from subsidence to likely discrepancy, as well as decrease fracture rate. So how many in the audience have cemented an elective primary total hip in residency? Yep. All right, so a couple. So that's pretty good. It's definitely not common in the United States. More than 90% of stems are cemented in Europe, but in the United States, it's quite the opposite. This is the data from AJR for 2020 that just came out. And what you can see is that there certainly is a trend to cement more stems from 2.8% in 2012, 2.6% in 2013, and then in 2020, we're up to 5.8%. So we're doing pretty good. If you break that out and you look at by age group, the majority of the cemented stems are actually in like 80 to 90-year-old plus age groups for that. And then this is also from AJR. And what you see is that both cemented and cementless or uncemented stems have a really great survival rate. I'm not going to say they don't have a great survival rate. It's over 99.7%, but the green is cementless. And this is within the first 3 months for elective total hips greater than 65 years old. What you can see is that cementless implants or uncemented implants, whatever you want to call it, do fail at a higher rate within the first 3 months, and that's due to parasitic fracture. So if you break it down into gender, what you find is that it's the female patients that are the ones that are having parasitic fractures in the greater 65-year-old group. The male patients actually, the cementless implants are doing better based on their data. So again, theme, older females, beware. These are patients you might want to consider cementing. This is another registry data from the Australian National Joint Registry comparing the 3 best performing stems for cemented and uncemented. So the uncemented stems were the Synergy, the Secure Fit, and then the Rectangular SL Plus for Australia. And then the cemented stems were like MS30, cemented stem for Zimmer, Composite, I-beam, OmniFit, and the Exeter polished P40 stems. So those were the 3 top performing, had the lowest revision rates, at 10 years. So those were chosen to look at. And they compared patients 75 and older, and what they found was uncemented stems had a 9 times risk of early revision at 3 months. And that was mostly for periprosthetic fracture and loosening. After 3 months, if they did well, they both performed the same. So it's really preventing that early periprosthetic fracture by cementing these older patients, greater than 75 years old. And, seeing these studies, I think really started to change my mindset on who I should be cementing. And you know what? If you can cement through the direct anterior approach, and it doesn't take much more time. Uncemented stems really gain popularity, I think, because of speed and ease of use. And so this is a study out of England looking at 360 hips. They compared a taper lock to a cemented Avenir. I think it would have been better if they would have just done Avenir and cemented Avenir, to the similar stems, but this is how they did it. And the mean age was 75. And again, what you're seeing is that the uncemented stems are having fractures. The cemented stems are not. And you ask yourself, well, how can you have equivalent surgical time, or 1 or 2 minutes more if it's a cemented stem? Well, the Avenir is almost like a press fit, highly polished stem that utilizes the French paradox. So you utilize a thin cement mantle. And so what you do is you put in, you prepare your canal, you do 3rd generation cementing techniques, you put in the cement, and then you put in the stem, and the stem will actually seat and hold. It's almost like a press fed. It is a press fed cemented stem. And so once it stops, it doesn't move. And so in this study, and I know several other surgeons that use this stem, and you can just reduce the hip, and the cement will harden while you're closing. So the indications for cemented femoral components in total hip, in my mind, are age greater than 70, female gender, poor bone quality, so dorsey bone or metabolic bone disease, diagnosis of osteoporosis, total hip or femoral neck fractures, and anyone who's a risk factor of fall. So I think if they have at least 2 to 3 of these, then you really got to consider cementing these patients. And I think you're going to see this trend continue throughout the United States. I'm excited to see each AJR's update. I think you're going to see that it's going to go from 5% to 10%, somewhere probably 15%. So what are the takeaways here? Again, we went over the patient risk factors, implant design, uncemented stems, and ML tapers are a problem, especially in the anterior approach because you lose that anterior metaphyseal bone. And then, surgeon risk factor, inexperience, and learning curve certainly put you at higher risk of fracture. Now I'm going to shift gears a little bit and go to some tips and tricks of femoral exposure. I think a lot of you probably know a lot what I'm going to say, but I'm going to show you a couple things that can also improve your exposure because really that's what it's all about. That's what makes the anterior approach so hard. That's why people are apprehensive to take it on or do some of these cases is because the femoral exposure is difficult. The acetabular side is really quite easy. And so it's all about exposure. So I think starting out with exposure, the 2 most important things in my mind when doing a case is one, my capsulotomy and the release of the pubofemoral ligament. And then also using the capsulotomy so I can see the full intertroch line. And what I'm looking for is I want to be able to feel the entire intertroch line, and then I want to feel the innominate tubercle, which is kind of superior and anterior on the greater trochanter. And right in front of that is the saddle. So I know my neck cut's going to go right in front of that innominate tubercle. And it's in every patient, and it's always there. What that does is a couple things. It ensures that I'm lateral enough into kind of the saddle with my neck cut that I'm going to have access to the greater trochanter to do my releases for the femur. If you leave a bunch of neck on the lateral aspect of the proximal femur, you really can't access or see the capsule or do your releases. And then you're struggling the entire time to get your retractor up and over. In fact, didn't really touch on this before, but putting your retractor just over the neck that you left into the greater trochanter can cause a fracture or damage itself. So really getting that right the first time is important. And then failure to complete the neck cut immediately is also an early mistake. And you try to pop the neck and make the cut. And what you're going to do is you're going to cause a calicar fracture. So you really need to make sure you complete immediately. And as you bring it laterally, you don't want to go too posterior because the greater trochanter is right there. You cut the tip of the greater trochanter off. While cutting the tip of the greater trochanter off doesn't change much for the patient. Their abductors attach about 1 centimeter distal and behind the greater trochanter. It is causing additional tissue damage and certainly style points. To see an X-ray and see the tip of the greater trochanter off is disappointing. So after you do your capsulotomy, release the pubofemoral ligament immediately. You need to get at least 90 degrees exposure before you kind of drop the leg down and in. I won't drop the leg until I get 90 degrees or extend the leg on a flat table. After that, the sequence of the releases are you release a superior capsule. And the majority of the time, that's all you need to do is release a superior capsule. And the superior capsule is basically at 12 o'clock, you can see you're just going to make your cut right over the greater trochanter and free up the capsule. And by freeing up the capsule, that'll allow the greater trochanter to come more ventral and lateral, and you'll have a good exposure. If you try to pull up with a bone hook or a hand hook, you haven't released that capsule, well, the capsule is going to be stronger than the bone, and you're going to have a greater trochanter fracture. So early on, I think surgeons get frustrated trying to get exposure, and if you're forcing something, you're going to break something. If that doesn't work, I'll release the conjoint tendon, which is right next to the superior capsule, kind of coming down into the saddle. I still don't have adequate exposure. After releasing the conjoint tendon, you get about 10 to 15 more degrees external rotation. Still not good exposure, then I'll do a reset. I was thrilled to see Dr. Cairo say he does a reset as well. I think it's definitely a game changer to do that. And so a reset is basically taking everything out, bringing the leg back up, going back to 0 degrees, pulling some traction. That allows all the capsule and everything to fall away. And then drop the leg back down, put the hook in, and see how much more rotation you get. You'll get 10 more degrees of rotation just by doing that. If it's a really stiff hip, fused hip, I'll release the piriformis. It's very, very rarely that I need to actually release the piriformis. But I don't lose any sleep by doing it. I don't think it makes a major difference, to be honest. It's all about exposure. Breaking a femur is worse than releasing the piriformis. You just release it. So this is just, you can see the circle there, that's showing the piriformis there. In obturator externus, I've never had this. That's a stabilizer, it's a medial stabilizer. I would really try not to release that, worry a little bit about stability if you have to release that. So this was that was an article in Arthroplasty Today. Actually, that was a really well done article. It's exactly how I do my releases. And happy to send it out to the group so you guys can check that out. But that was really done. It's actually, it's how Dr. Kairos does his releases as well. So for the residents, you can send that out. So what about additional exposure? What if you need to put in a long cylindrical stem? What if you need to put in a conical stem? Or what if you're just having there's a large muscular male, it's a really tight tensor. You can't get, again, you can't get direct access to the femur. You can't get that collinear. So you can do a tensor fasciolatus snip or a TFL snip. I liken it to a quad snip and a total knee. Okay, it's a tool that we use to increase exposure, and we don't have to change the protocol as far as recovery. So TFL, you find the SAS about 1 centimeter distal is the musculotendinous junction. You take the tendon and you cut it, tag it, and it allows the tensor to fall out of the way. It falls lateral. So now you're not fighting the tensor. You know, you can take 25 to 30% at first, see if you have exposure. If you don't have enough exposure, you can take more, you repair it. You don't need to change their protocol at all. I don't think patients do not have increased pain. And again, it's all about exposure. Additional tools that you can use are the double offset broaches, which I know Dr. Kairos uses, and then or a single offset anterior based broach, which allows you to kind of drop down and in. This is a picture of where the femur is and how you have to get to it. And you can imagine if you're trying to use a straight broach, this just isn't possible. So those were kind of the tips and tricks of femoral exposure. And now you got to know if you have a fracture, you know what to do about it. And this is true for both intraoperative and periprosthetic femur fractures. The Vancouver classification works great because it, you know, evaluates the location of the fracture, whether the implant is stable, and bone quality. And so, you know, type A is kind of proximal metaphysis, greater trochanter, lesser trochanter fractures. B is proximal metadiaphysis, and C is kind of distal to the stem. And then the intraoperative fracture, there's subtypes classification, which is cortical perforation is 1, 2 is non-displaced, and 3 is displaced. So let's get to what you got to do to fix these. So greater trochanter fractures. So you can see on this X-ray, this is like a chip fracture. This happens either 2 ways. One, forced retraction without adequate capsular release causes a pull of the trochanteric tip, and you get these kind of fracture fragments coming off the greater trochanter. Or you cut it with the saw when you're making from that cut. These don't have abductors attached. You treat them non-operatively. You do have a greater trochanter fracture that includes, that goes distal to the vastus ridge. That can happen with the anterior approach. It can happen with femoral tapers. You can treat those non-operatively. I think going lateral and putting on cerclage wires and a hook plate can cause more problems. With the anterior approach, you're not interrupting any of the soft tissues laterally, including the abductors, the lateralis, and that hook bridge. And so those don't tend to superiorly migrate. They stay where they are. They'll heal. Patients don't have significant abductor function. Where if you talk to a patient, you tell them I'm going to put a hook plate on, and I almost guarantee that you're going to have trochanteric bursitis and want to get it taken off. I don't think you're going to make it much better. And so most people opt for non-operative management of that. Lesser trochanter fractures, I would really be aware of. Isolated lesser trochanter fractures are pretty rare. It's probably a displaced fracture. I would guess, or a non-displaced fracture you're not seeing. Get a CT scan. Most of the time, sometimes you need to do a cable and a long stem for those. But lesser trochanter fractures are really isolated, are really quite rare. Usually, it's a subsidence that causes a lesser trochanter to pop off. And those implants are not stable when that happens and need to be revised. Calcar fractures. You can see that both intraoperatively, just looking at the calcar during broaching or final stem insertion. If that happens, you remove the implant, cable it, and then reinsert the implant for that. And then cortical perforations, like you saw before, if it's very proximal in the metaphysis, usually it's just a small hole from the tip of the stem, and you can, as long as you redirect your stem and use a longer stem to bypass the 2 to 3 cortical diameters, it should be fine. I think if it's more distal in diaphysis, you do need to place cerclage wires distal to that. So this is an example of a calcar fracture with a cable insertion of stem. That's tolerated. So B fractures, if it's not a displaced stable implant, you can just cable. Most of these early on, if you have a type B fracture, are going to be displaced and the implant's going to be unstable. So that requires a revision. And so if you just did an anterior approach, you're really going to go back and do a posterior approach for the periprosthetic fracture revision. If this happens a couple days after surgery, 6 weeks after surgery, I think the answer is no. You'll make them unstable by doing approaches. So I do these revisions anterior. And so if you're doing anterior approach, I think you got to know how to do these because inevitably you're going to see these fractures. And so for these, you remove the implant, fix the fracture, and then put in a long diaphyseal stem. And so, how do you do that? So this is the distal extension for the direct anterior approach. There's been a lot of people that have said, well, anterior approach isn't extensile. It is extensile, but it's proximally distally. And this is how you do it. You basically take your incision going from the anterior approach to lateral, and you're going to do a lateral approach with the subvas and raise the vastus lateralis with subvastus approach. So you bring it lateral, and you basically work in 2 planes. You have your anterior approach plane and your lateral approach plane. You don't want to go in between the rectus and vastus lateralis distal to lesser trochanter, because that's where the perforating femoral nerves that are innervating the vastus lateralis. And if you bovie right down past that, you're going to cut those nerves and deinnervate the vastus lateralis. So you kind of work in between the 2 intervals. And so you come lateral, you go through the IT band, you do your subvastus approach, start distal to come proximal, getting the perforators as you go. You can do an L in the vastus lateralis right above the ridge, leaving a cup. So you can flip that up if you need additional exposure proximally, and then repair that at the end. So normally I don't have to do that. Then you can fix the fracture, pass your cables, and put in a long stem. So this was the case early on with this patient. So she got a Wagner stem for this. And I would say, in hindsight, knowing what I know now, I would have cemented her and probably and should have. She's 73. She was healthy, but she was female and she had dementia, Alzheimer's dementia, and she's going to be at higher risk of falls. So should have cemented, may have prevented a fracture and a reoperation for her. And then type C fractures are distal to the implant. These are pretty rare intraoperatively or postoperatively. If you get it intraoperatively, you're really doing something wrong. And these are going to require a plate and cables and screws. And if it's close to your implant, you need to bypass that implant. When these fractures are really a problem, it's when they're right distal to the implant in a transverse fashion. That's a lot of stress. And I think for those, you're going to need something like 90-90 plating or a plate and cortical strut, because transverse fractures right distal to the stem tend to have a high complication rate, low healing. But again, those are pretty uncommon within the first 90 days of surgery. Those are coming in, years later. And finally, see the fractures before they see you. So look out for those patients that are high risk of fracture and cement them. Do something different. Don't use a taper wedge stem. If you see a calcar fracture, address it at the time of surgery. Don't say it's going to be fine. Find out a couple of days later. And then I utilize fluoroscopy for anterior approach. So what I do in all cases with the trial lead is I do an AP and lateral X-ray. And so I know that the stem is in the bone. I don't have a perforation. I do that also for revisions, anterior with conical stems to make sure my stem isn't out the back. And I just sleep better at night doing that. And I also get to look to make sure there's no, I'm concerned about a fracture. I'll take an X-ray, take a fluoro of the fracture, you can image the entire leg, really with the patient on the table. Because what you want to avoid is just a bad day in the OR. And so what you can see is, we got this AP X-ray. A, it looks okay. Maybe in hindsight, some looks a little funny, but it looks okay. It's pretty good. And then B, and this is the PACU X-ray, immediate PACU. What's going on? Call up to radiology and say, hey, can you guys shoot a cross-table lateral? Something doesn't look right. And C is what that cross-table lateral looks like. So now you got to call the family. You got to talk to the patient who's just waking up, and you got to take her back to the OR. And because this was proximal and metaphyseal, a long summit, there was plenty to bypass this step. So takeaways are, periprosthetic fractures are a complication in all approaches, but certainly I think femoral complications are more common in direct anterior approach due to difficult exposure, learning curve, and some technical difficulties. I think if you plan and consider who's at risk and consider cementing more of these, you can stay out of trouble and hopefully lessen that periprosthetic fracture rate from 0.8 or 1% to closer to 0. And then quick recognition and diagnosis is really key. Thank you guys, and take any questions. Yeah.
Take it down, look at size. It's usually
Yeah. 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 So first question. I think what happens when you lose that rotational stability in those patients is you probably had some rotation when you were broaching and maybe didn't realize it, and you lost whatever extra, metaphyseal bone they had. And then so now you're dealing with just, cortex proximally. And so there's nothing for that broach to grab. The two things, I'll do in that, I'm hesitant if I'm at the size. I'll take a lateral. So depending on what stem you have, it's good to know if there's a bigger medial lateral or anterior posterior. If there's a bigger anterior posterior, you need to check it on a lateral. The lateral looks like there's room to go up. You could consider going up. If there's not, or you're like, I'm really happy, I don't like this bone, just cement it. The third option, if there's some reason you don't want to cement it, then you got to do it like that. So engaging, like longer stem. Bypass it because you don't want to be loading that bone. They're just going to have a fracture. If I have a low threshold, just cement them. Just cement them. You'll sleep better. Not to worry. I think the collar definitely helps, and I'll tell you that I think you can tolerate a little more. Because the collar is going to give you some rotational stability. But in a patient like that you're describing, you just. And then the second question is early revisions. I do an extended antibiotics. They are at high risk for infection. They're not only at high risk just for they're high risk for C. acnes. I think with anterior, I think there's probably a little higher risk. It's been borne out. Certainly, there's a couple studies that have come out that showed anterior approach had higher risk of infections. I think those studies were a little biased by the people who did them from these tertiary referral centers. Probably wasn't fair, but I give them all extended antibiotics. I think the benefits outweigh the risk. If they're an older patient, I'm giving them some oral gut health, lactobacilli or something as well. Whether it makes a difference, I think it does. But the last thing you want to do is give someone C. diff either. But I think I use most of the days are cefadroxil. Cefadroxil we don't have at our pharmacy in the hospital, so I'm using either Catflex or Doxy. Someone's MRSA colonized, so I use Doxy. It's very well tolerated. Yes.
Eric, that was a fabulous talk, so thank you very much for coming. A couple of questions I have. I'm surprised the residents don't get a lot of cementing experience, although we have got back to doing some osteoporotic patients. So my question is, you laid out the risk factors for periprosthetic fractures intraoperatively as far as demographics preoperative. So you have a 90-year-old female who has osteoporosis, and then you're planning a total hip amputation. So do you still do an anterior approach, but then decide to cement it ahead of time, or do you do posterior approaches just because of that? So when you say cementing it, do you just cement it, doing it the same way you would normally do it?
Yeah, so I'll do an anterior approach and plan ahead to cement those patients. I think it's not only just the cementing, for initial implant stability, but those patients, regardless of approach, I think you have to be very careful and ginger with it, with them. So I don't force anything. I don't force the reductions. Very careful about placement of my posterior retractor around the trochanter. I'll typically do that placement because if you don't have the feel, don't know where you're going, you'll put it right in that patient's greater trochanter. They're so osteoporotic. I like the stability with the anterior approach. So, when I weigh the risk benefit of a 90-year-old patient, to give them a stable hip that's not going to dislocate, and then just cement it so I don't have to worry about periprosthetic fracture, I think I've given them the best chance they have at a solid recovery.
So the other thing is I'm kind of older than most people in the room. So I grew up cementing stems. So I'm pretty sure I cemented more stems than anyone still practicing in New Jersey. But there was a whole technology about cementing stems. The stems were designed for cement, and there were criteria about how you would prepare the bone and put a cement plug and then plan for a particular size cement mantle around the whole stem. So when you cement a stem anteriorly, what stem do you use? Do you just do a press fit stem, the same stem you use, and just add cement to it, or do you switch stems and use some different model?
I switch stems. I think I like the Avenir. It's a fully polished stem with a thin cement mantle for those patients. And so you also have the option of press fitting or cementing that stem. So it's the same broaches. So it's the same workflow. So it really doesn't change your workflow at all. And I think that was a point of the paper, that England paper, is that I think surgeons in the US are apprehensive to cement because it takes more time. But with that stem, it really doesn't take that much more time. So you broach, you can trial, and then measure, place your cement plug, irrigate the canal, dry the canal, and then cement and pressurize. And then once you seat that stem, there'll be a point where you really can't push it down anymore because it's fill. It's like a press fit stem that you cement. And so it is a thin cement mantle. It's kind of gone away from the 2 centimeter cement mantle that we use. Now, to be said, I do it both ways. I do use a Summit for my hemiarthroplasty fractures because that's what's on the shelf. And that's what we have there, but happen to bring the cemented options. I think Summit's a good stem too. It works differently though. It's the recommendation is a 2 centimeter cement mantle. So if you broach to a size 5, size 5 cemented stem is actually a size 3. So it's 2 millimeters different to make that cement mantle. So kind of two different schools of thought as far as that goes. I encourage you guys to check out, there's a really good AUKUS lecture. If you're an AUKUS member, residency AUKUS member, it's free, that Brian Springer and a couple of guys from Exeter, England did. I think it was like 3 or 4 weeks ago. They talked about cemented stems, and then Joe Moscow went over his approach to how to cement a stem, the anterior. And really what you'll see is it's really the same thing. You do need a direct line to the femur because you got to place that cement plug in. So you have to have good exposure. But it's the same thing, same workflow. I think you'll find it very easy to do. The other thing with cemented stems, I didn't really touch on that, but with hemis and totals, I think you got to look at the whole picture with a patient. If there's a patient who maybe is elderly but has significant cardiopulmonary risk factors, there may be a reason not to do a cemented stem on them. And if I'm going to use an uncemented stem, I'd use an uncemented stem with a collar. It gives you extra support. Dealer's choice, which one you have on the shelf here, but I think a collar helps me sleep a little more at night. But those really bad cardiopulmonary patients who can't take a hit from the cement, I'll consider that. Because when you look at the data for hip fractures and mortality with cemented or uncemented stems, what you'll see is the first day or two, cemented stems have a much higher mortality than uncemented stems. The reoperation rate within the first 90 days for uncemented stem is much higher. So you got to weigh those risks. Low percentage. I'm cementing more and more. And as far as periprosthetic fractures, I think we all have them. I'll have 1, maybe 2 a year. Do a lot of hips, but those are the ones I wonder. Maybe I made the wrong decision. So you're not gonna be able to get rid of all of them. Fix all of them. But at some point, someone's 75 and older, loaded man, maybe just cement it. The nice thing about a highly polished stem too is if you do need to do a revision, you can just pop it out. Do a cement if you need to. So there's some advantages. I think our residents don't get much exposure to it either. I think it's good that's going to be changing. Absolutely. And I think as you do more, you get more comfortable, but it's still very stressful for me. I think for everyone, you got a hot room at the end of the day, and cement's set up quick. Great questions. Any other questions? All right. Thanks, guys. Really appreciate it. Yeah.
Yeah. Yeah. I went. Yeah, I went. So this lady, she's terrible. Short. She's no, no payment. I know. Yeah, yes. Huh?
up here?
I didn't show the X-ray. I did. I think you may have done bilateral, but I thought it was going to be too hard for me. This guy,
Oh, yeah.
he's like 42. He's a mechanic, and I mean, you can see how big he
Yeah,
is. That's his
well,
belly, and like all this is just bone.
Yeah.
So I did this hip, and then you got him on for that.
Okay.
But I was like, oh, I didn't want to do bilateral.
Yeah, I mean, I think that's fine. I mean, that's it. I'm sure that was a very tough exposure.
Yeah, I mean, like there was just all. So before he even got to his tab, I was just taking out osteophyte, you know.
Yeah.
And then I put the cup in, and I took more osteophyte out. It's crazy.
I think it helps if, you know, if they have an external, a lot of this external rotation.
Yeah.
Retractor.
Yeah, he did. You're
I
right.
just, you know, release the conjoint tendon of your performance.
Yeah,
And
I just take it.
definitely
I take it
just
all right away. I just go.
Yeah, right away. Yeah, I don't even think about it. Especially in a,
So what do you guys want to do? Yeah, so I have both, but I don't know if you guys want both. Yeah, so I could do this have a fracture one. It's about fractures and a little bit about what is poor prognosis. I don't have any cases. It's not like yeah. All right, yeah, I think we can do this one. Yeah. Okay, cases on this one. I haven't, no, but I think it's a good idea. I mean, it's a good idea for certain patients. Nice. That's slick. He's slick. That's slick.
really. She had a Yeah.
I wonder, like, see if I can get this to go up. All right, cool. You guys want to, I got another talk for you guys. We'll do a quick talk and then I think you guys have cases we're going to go over here. All right, so this talks on geriatric acetabular fractures. I'll talk a little bit about, let's see if we get this slide. Hold on one second. All right, we'll talk a little bit about the epidemiology, how to evaluate and manage these patients from the ER to the OR, and then treatment options for these patients. They're becoming more and more common, so I think it's an interesting topic to talk about. You know, it's not directly arthroplasty, but more and more than we're getting arthroplasty. So it's really difficult. These patients are osteoporotic, they're low energy falls, and they have really poor outcomes with ORIF compared to their younger counterparts. There's been over a 2.4-fold increase in geriatric acetabular fractures in the past 27 years, and they're really the fastest growing group of acetabular fractures. You'll be seeing more. And the mechanism typically is a low energy fall on the side of the hip onto the greater trochanter. The greater trochanter basically comes a little external and hits the anterior medial portion of the anterior column called quadrilateral plate, which is kind of the classic fracture patterns for these patients. Usually anterior column, anterior wall, anterior with posterior hemitransverse fractures, or something like that that's really not classifiable. So when you see these patients in the ER, you know, they need a full trauma workup. They need, just because they have a ground level fall, you know, these patients can get sick. They can get hypotensive. They can have displacement of the SPR, IPRs causing and get like an operator bleed or intrapelvic bleed. So don't dismiss these patients. You really need to keep a close eye on them. This is really just general trauma evaluation, which I'm sure you guys already know and how to do. I think you should check vitamin D levels on all these patients. And then, do you guys have a geriatric co-management team here, or like medical team that manages admit medicine? Yeah. So we admit most of these patients. The way it works at ours, and then we have a geriatric team that will kind of help. I think having geriatricians involved is helpful for these patients. It also helps kind of steer goals of care and risk for that. So AP pelvis, CT scans, and then I think J-days are really helpful for following these patients in the office, either if they're going to be non-operatively treated or operatively treated. But you get J-days, sometimes are more helpful than a CT scan for these fractures. And you know, you guys learn the classification. However, really geriatric fractures don't necessarily follow the classification. It can be difficult to classify. So again, they're mostly anterior column quadrilateral fractures. So you guys know what the poor prognostic signs are for acetabular fractures. Poor prognostic signs meaning fixing it's not going to do well. Marginal impaction, yep, that's one. What else? About pre-existing arthritis. That's a layup. What else? Goal sign, yep. Who knows what a goal sign is? Yeah, it looks like this, like a goal. What is it? Is it threes? Third years. It's like a superior medial dome impaction. I'll show you guys a picture here in a second of what it is. Once you see it, you're definitely going to remember it forever. But it's like basically some marginal impaction, but it's more superior medial. So marginal impaction associated with posterior wall fractures, posterior wall fracture combination. You have combination of posterior wall and osteoporotic patient, not going to be able to fix it. Spring plate's not going to work. Femoral head and neck fractures. So femoral head fractures are really a problem in this dislocations or femoral head impaction. So acetabular fracture with anything going on with the femoral head, arthritis, fractures, gonna be a problem. So this is what the goal sign looks like. You see that superior medial dome impaction. It's really hard to fix, and these patients progress to arthritis pretty quickly. Again, here's another one. Superior medial dome impaction. Here's an example of marginal impaction. Posterior wall fracture. So treatment options. There's multiple things you can do for these patients. You can not operate on them. Sometimes that is the best. Perk fixations getting more and more popular versus ORIF. Are getting less popular in these patients. And then either another option is doing combined ORIF total hip. That's working with trauma team and arthroplasty team to do an ORIF total hip. And then in some patients, you can wait 8 to 12 weeks and let things heal in, and then just do a total hip to do one operation. So we're trying to figure out which is better. Takes out, you got to know the patient, their medical comorbidities, but also understand the fractures. So there's not a lot of outcomes or clinical data on non-operative treatment. No one's really studying this, but they're really reserved for minimally displaced fractures, both column fractures that have secondary congruence. I'll show you what that looks like in a second, or someone who's like super sick and can't have surgery. So treating in patients in traction, we really don't do this anymore. I think they're going to get, you're basically death sentence. Okay, the geriatric acetabular fractures have similar mortality to fractures anyways. When you put someone in traction for 2 to 3 months, they're going to get decoup ulcers, aspirated. It's really not an option, so don't do it. So secondary congruence is in both column fractures. It's great for low demand patients. It really gets really good results in low demand patients. So despite the x-ray, you'll be surprised when you see them in follow-up how well they're doing. And so with a both column fracture, basically the fracture patterns separate and they kind of form secondary congruence around the femoral head. And this allows the fracture to settle and heal right around the femoral head. This is what looks like as this thing is healing here. It's like 6 months out. Patient's finding, you know what, if this patient was maybe higher demand than we thought and was having problems, well, then a total hip is a good option. The only thing I'll tell you that doing a total hip in this patient, really need to consider what you can do for acetabular fixation, because they do have a high risk of loosening. Because what happens is it's really hard sclerotic bone. It doesn't have a lot of great ingrowth for a cementless. In fact, you may consider cementing cup in this, or grafting using a TM cup and a bunch of screws. They just have they have an extremely high loosening rate. ORIF is an option. It definitely has a lower complication rate than ORIF with total hip, right? It's one surgery. You have less variables. You're not doing a total hip. You don't have risk of dislocation. Plus, if they do get infected, you wash it out, whatever, it's fine. Versus if it gets infected and there's a total hip in there, and can have great results as long as the patient doesn't have those kind of poor outcome indicators on their CT scan and X-rays. So, can you fix it? And can the patient tolerate it? And really look at those images. So perk fixation has become popular to kind of stabilize fractures, allows recovery. And if you fix it and they get arthritis, oftentimes you don't have these prior scars or incision to go through. So, but I will tell you that these like anterior column screws can be kind of a problem with doing an anterior total hip. You really got to stay away from it. Anterior total hip, any total hip. Stay away from it, or you may have to cut it out, or you do have to do a total hip for that. There's options of perk fixation. This is, they removed the screws and did a total hip for this patient after the arthritis progressed. It's really kind of a nice way of doing it. Converting these patients, conversion rate for patients older than 55, even if you do a great job fixing it, is pretty high. It could be, 20%, where all age groups it's about 8%. So 1 in 5 patients who have a scapular fracture are going to progress post-traumatic arthritis and need a total hip. Just something to keep in mind. So we're talking about someone who's 75 or 80, you may consider just doing the total hip right away. So they're not going back for a second surgery. So we talked about predictor poor outcomes, the prognosis signs. Increased age is also a poor predictor. Again, bonus, worse quality. So the advantages of combined ORF total hip. Of course, I'm a low bias, so I like doing these, but it's early weight bearing. So they typically our weight bearing is tolerated right away, rather than 3 months non weight bearing. So take a geriatric patient and tell them they can't walk for 3 months. Well, let me tell you something, they're walking anyways. You can't non-weight bear a geriatric patient. So they're walking anyways, but this allows them to mobilize quicker. It's one surgery. And you have teamwork between trauma surgeons and orthopedic surgeons to do this. So, looking at what do you tell a patient if you're talking about ORF versus total hip is basically combined procedures, more surgical time, more blood loss, but has better outcomes. Mortality rates are really no different. Again, you can see on the bottom, the conversion is about 20%. So 20% of patients get ORF and you get total hip in these patients. You're not worried about the fixation. Yeah, you're like just kind of throw it together. Spash it together. Make sure your screws aren't in the way. That's probably the biggest thing. Is that you got to talk with trauma surgeons. Trauma surgeons like screws close to the joint, but you're doing a total hip. You don't need to put them. You don't need it perfect. You don't need them close to the joint. You just need something stable, so you can put a total hip in. So it takes less time for that. And there's you can get away with maybe not fixing this fracture fragment or that fracture fragment. There's small posterior walls with a lot of combination. You can literally just excise and put in a total hip. It's not even a combined procedure, so that's quicker too. So I can skew outcomes. Definitely more blood loss with combined. So this is just an example. Posterior wall dislocation, elderly patient, total hip, weight bearing is tolerated. So delayed. There's better outcomes if you fix it right off the bat than delay them. Sometimes there's medical issues. Certainly during COVID, I think if someone has a geriatric acetabular fracture and they have COVID, you may want to delay that fixation. Right, they have higher risk of mortality, higher risk of clots. Maybe you wait 3 months on that one and then do it delayed. There's certainly reasons to do it delayed, but if you can do it in the acute period, the patients do better. They're not losing that muscle mass. They're up and in, recovering quicker. And again, the sclerotic hard bone makes it difficult for these acetabular implants. It's important to understand that delayed total hip is not a primary total hip, and a combined total hip is not a primary total hip. These patients, especially combined and delayed, have a high risk of heterotopic ossification. You may consider radiation for these patients. In fact, I radiate all of them, and if they can take NSAIDs, take NSAIDs, although not all of these patients can. A much higher rate of dislocation, even if you feel that your components are in good position, the posterior structures, and especially posterior wall dislocation, are just destroyed. And so you have really no stability. So I've had cases that I thought I did really well on that dislocated multiple times because of that. There's nothing there, nothing there. And they have a much higher risk of infection. This is someone I would also consider doing extended oral antibiotics for, because combined or delayed total hip infection is just catastrophic. I'll just kind of go through this. It's just showing that, delayed outcomes. That initially there was like a higher revision rate with the cemented stems, cemented cups, because of the hard sclerotic bone and not getting any cement penetration. I think if you can use a highly porous cup, lots of screws, it's probably better. So bone graft medially for these, and revision rates are much lower for that. So finally, do you fix it or not, or delay it before a THA, total hip? I think it, depends who you ask. I personally think it's probably, if you're planning to do a total hip, just delay it if you can, rather than fix it. Less scar, less hardware to deal with. Hardware is a problem. But if you think you can fix it and do a good job, fix it. They need to look there. So everything's different. You got to take everything into account. There's all these treatment algorithms. Really, I don't think they're that helpful. You just got to talk with your trauma surgeons and be realistic. And 20% go on the total hip. So if there's 75s, you don't be a hero. Try to do a combined procedure rather than just trying to fix it. That's it. You guys got any questions? It kind of depends on the case. The ones I've done dual mobility, the neurosurgeon is one that fuses the entire lumbosacral spine as well. So I did dual mobility, and guess what? He dislocated. Anyways, so that may be a role for dual mobility. I don't do a lot of dual mobility to begin with, but it's certainly something to think of. I'll do like a +4 10-degree liner. I like that better with a 36 head, and I really try to get to a 36 head. That gives plenty of stability. Like, pretty sure this is a +4 10-degree liner, posterior approach. I've done them both ways. I think you could just ignore it and do an anterior. The only thing I guess will say is that all the trauma is posterior, so now you're kind of gone anterior and posterior. You can do it. I've done it. I don't know if it makes a difference. Right, that's what you got to wonder. That's tolerated. Yeah. Again, typically older patients and can't toe touch anyway, so they come and walk in. I mean, I did, a cup cage with huge acetabular bone loss, and I wanted her to be toe touch. She came and walk with her walker. She's like, "Look, I'm touching my toe." She weighed like 200 pounds. 5 foot tall, 200 pounds, all the weight. So, yeah. But no, I think there's a good question about the posterior wall small fracture. I don't know the answer, to be honest with you. You can do it either way. They probably have risk either way. It definitely would be easier to do anterior because you don't have to deal with all the trauma posteriorly. Like, it's very disorienting going back there. And, yeah, because honestly, I've done some of the posterior walls, but as of late, I just do it with the trauma team because they can do it quicker than I can. Right? They're a little more facile, just bending the plates and stuff, so they can do that part quicker. And we've kind of got like a flow that they know not to put the screw. Like, first couple of times, the screws were in the way, take a screw out, this, that. Now it's like, all right, we know you don't need this perfect kind of thing. So, and then like the ones that are anterior column. So yeah, they're a real problem. I think Val showed a case at a conference where, you know, they did a combined total hip where they did perk screws and then a total hip and the screws in the way. So on those type of things, I would have them do like a plate, a buttress plate, like right here. Yeah, exactly. Buttress it, and then draft a little medial ream, put in multiple cup, so it stays out of the way because the screw is going to get in the way no matter what. So it sounds like a good idea, but if you're doing, I wouldn't have them do a plate, screw buttress plate. So, always good to learn from mistakes. All right. You guys got some cases?
So I have a couple cases, complex cases to present. First case is a 72-year-old female who came to emergency department complaining of right hip pain and difficulty to ambulate for about 6 months. The patient at the presentation was wheelchair bound. She denied any recent trauma, any fever or chills. Her past medical history is significant for diabetes, hypothyroidism, chronic anemia. The patient suffered from DDH, and for that reason, she got total hip replacement in 1979, and subsequently she got revision hip arthroplasty in 1991 due to periprosthetic fracture after mechanical fall. So the patients came to ED and the X-ray was performed. That's the X-ray from the presentation. So the patients' basic labs were sent and they came back. As we can see, white blood cells 10, ESR 134, CRP 7.35. There's like significant osteolysis and bone loss around the acetabulum and proximal femur of the X-ray. So we decide to proceed with the CAT scan. So CAT scan. So we're looking for this bone loss, and the CAT scan came back and was read by the radiologist as a significant bone destruction, and finding are most suggestive for sarcoma. So the patients got basic workup, including so that's what we did. So we send the patient for an MRI. So, yeah. So radiologist was evaluating the MRI and they suggesting that this is pseudotumor. Anyway, we did like full workup for tumor workup, CT of chest, abdomen, pelvis, which was negative, all labs, which were negative for tumor. We didn't find any primary tumor for this patient's medicine, evaluated the patients. So now we stay with this diagnosis, which is most likely pseudotumor. So when we got this idea, we decided to aspirate the hip and also take a tissue sample and just prove that there is no tumor. We also sent serology for the metal ions, came back negative. So the question is, what would be the next step for these patients now? So CRP was high, ESR was high, aspiration, cell counts are high. There is high number of polymorphonuclears.
You're not getting lucky on this one. I don't care if you on the chat, the PowerPoint.
And what do you think about the cup position? Is the migration or the cup was primarily set there after revision? She got periprosthetic fracture. We don't know. We don't have any films from. Yes, it was in 1991, so no X-rays were saved from that time, and it was in a site hospital, so we couldn't get any documentation. It looks like the center of flotation is very high, and it's fixed with the screws. So maybe that was intentional. Maybe the patient got acetabular fracture, and the cup was placed high, or it migrated. No, she had no history of infection. She got periprosthetic fracture that was negative for infection. She got revision total hip, and it was 30 years prior. So for these patients, there is no rush. She's with this problem probably for 6 months or even longer. So waiting 1 week probably doesn't change anything. We can plan our next step and wait. Actually, so what we did, send this. There's another question, if there is particle disease and pseudotumor, if our aspiration is adequate, because our criteria for fluid cell count is more than 3,000, but sometimes in metal, it can be higher. So there's another question if it's 3 point for MAIS criterion or not. So what we decided to take these patients to the OR and remove everything. And we sent pathology. We sent cultures from the OR, and the culture came back positive for Slachia xingua. We couldn't put the spacer because there was like significant bone loss. So the patient is wheelchair bound, so she's not ambulating, even though put the antibiotic. So our next step was to start antibiotic. So patients were started on 2 antibiotic, metronidazole. And after completing the antibiotic, we did antibiotic holidays, and we checked for inflammatory labs again. They were negative or normal. We sent the patient for aspiration, came back negative. So we decided to do the second stage. And our question is, what would you recommend for the second stage for this patient? It's almost like hemipelvectomy with the triflange. It's almost like hemipelvectomy. There's no like. And when you do the triflange, you would restore the center of rotations, or if you have custom made, you would put the center of rotation in the same position. And then you would you shorter the femur, or so that's the only option with the triflange implant custom made, correct? So with triflange, so I know that the Striker has this option. I don't know if other companies have. Biomed. So you get locking screws in the ilium and the ischium, and in this case, there is no anterior column, so you cannot put the screws in anterior column. So I can tell that we don't have this option in the hospital. So what would be your plan B? And what's your selection? Is that even possible to bring down the cap cage construct if there's no bond there? Sorry, I get this. Yeah. On the ilium ischium and then augments on the top. So the jumbo cup and then in this construct. Okay. Cannot stop. It's going. Yeah, yeah. I mean, this is guy I have tomorrow. Share it over. Patient can wait better. So that's what we did. What do you think about this construct? That's what we did. We sent full cultures, multiple cultures. I believe it was 13. All came back negative. So 5 months follow-up. She was non-weavering for 3 months. And after 3 months, we start physical therapy for the patients. No. It's 1 year follow-up. It's 2 years follow-up. In meantime, she fell off the stairs and she broke proximal humerus. But the hip was great. So now she's 2 years from the kid. I don't know the preparers if we have the option for tri-flange here or custom made. I never seen. I don't think. So that's a. Second case, 62-year-old male. Year ago came to the office complaining of the left hip pain. Patients had past medical history, significant depression, chronic back pain. For that reason, he was on gabapentin, Percocet. Of note, the patients got a femur fracture many years prior. He was fixed, removed the metal, and 4 years ago, he got right arthroplasty. His BMI is 36, so he's a big human being. So he was indicated for the left total hip arthroplasty. We did it on the HANA table, direct anterior approach. Everything went well. Patients went home the same day. First follow-up, there was no issue. However, 2 weeks later, patients appear in the emergency department in the hospital after fall with the head lacerations and mental status change. Mental status change was probably related to the alcohol level he got. And all trauma workup was performed on these patients, including CT of chest, abdomen, pelvis. And patients, because of the mental status, was admitted to the hospital. The next day, the physical therapy came to the patients, and they had difficulty to work with the patients. He couldn't ambulate. He was complaining of the thigh pain. So ortho was evaluated for these patients. Foot X-ray was negative. He got a CT of the chest, abdomen, and pelvis. And the CT abdomens ended up at the level of the lesser troch for 3 days. So the CAT scan was exactly cut here, just above the fracture. So he came, we find out this B2 periprosthetic fracture, and the patient was taken to the OR for open reduction, internal fixation. The thigh was massively swollen. At the end of the case, we couldn't close the fascia, so we put the vac. It was like impending compartmentation. He was huge, and thigh was huge. And when we cut the skin, it was open. Even positioning these patients on the table was difficult. It was extra effort to move these patients. Hold the leg during the case was like a struggle. Would you do something different? Using this to prevent refracture. Yeah. To go higher. So the patient was doing great. The next couple of days, he came back for femur IND because the wound couldn't be closed. We replaced the VAC. Finally, we engaged the plastics, and plastics covered the wound with the skin grafts. And the patient was discharged home. He was recommended. He refused to go into the rehab. He went home. He was total weight bearing. Sent him all DVT prophylaxis, and pain management was engaged for pain control for these patients. So this patient was doing great for 2 weeks, and 2 weeks later, he came back to the hospital, to the emergency department. He was trying to grab the sandwich in the kitchen. He put weight on the leg and felt sudden pop. So he decided to go to the hospital, check what's wrong with his leg. That's the X-ray that we obtained in the emergency department. What's your thought? What you predicted that? So what would you do next? 2 weeks. So it's 8 weeks. Sad. It was difficult. It was B2 for sure. B1. So now to be B1. So we just did the incision just above the skin graft. Yes, yes, there was a strut. And the next day, we also took some cultures and intraoperatively. And the next day, one of the 5 cultures came back positive for stuff. 1 of 5. Yeah, only one culture, number 3. So that's what we did. We called ID for consult. Even if it's 1 out of 5, we decided to start treatment for that. The patient started on sulfasalazine, got peak placements, and we decided to follow CRP-SR weekly to monitor the trend. And he was non-weight bearing this time. And he was sent to the rehab Xarelto for DVT prophylaxis. So the patients came for a first follow-up visit about a month ago. That's the X-ray. You can see like bridging colors on the medial side. What's different comparing to the first X-ray is some subsidence of the stem. According to the patients, he was strict non-weight bearing. He was using wheelchair for ambulation.
Yeah.
So we decided to follow up him closely. He came back for another follow-up visit. It was 3 months later. So now we see a lot of heterotrophic ossifications or new bone formation or it's a question. It can be heterotrophic ossification. It may be periosteal reaction. So the patients came for another follow-up visit, and there was even more bone formation. So this time we decided to do inflammatory workup. As you said, our suspicion was that the patients can be infected. We also sent him for MRI, which came back with some collection of the fluid. It was undetermined. So we decided to, and inflammatory lab came back elevated. So we decided to send these patients for hip aspiration. Also, meantime, he got COVID. So we weren't sure if the inflammatory labs are high because of his viral infection or it's all related to the hip. He couldn't ambulate. He was complaining of the pain. So we decided to send him for aspiration, which didn't help us too much because it was dry tap. What would we do? This situation. So we were waiting for 1 month for this patient. He got COVID like in end of January, beginning of the February. So we decided to take the patients to the OR for open biopsy because our criteria were not clear and we were suspicious for infection even if we didn't have a proof. So we decided to take the patients to the OR for open tissue biopsy. And when we opened, it was frank pus. So I believe it was. We staged him. So he came for open biopsy. So the biopsy was done on March 31st. The patient came back for a first follow-up visit, or culture negative. There's a lot of bone formation. Oh, he got a peak line, so that's something I did. I think it was cefazolin, but so the patient came back 2 months later, and we decided to check inflammatory lab. We were within normal limits, and we sent him for another hip aspiration. And this time we sent him for PCR bacterial sequencing as well. All results came back negative. So because clinically he improved, he stopped complaining for pain, labs are all negative. So would you proceed with the second stage or? So we're waiting for 1 more month, and we decided to do the second stage for this patient. We claim. Negative, all cultures negative. He got a couple of nerve blocks in meantime, I believe, and pain managers slowly wean him from narcotics. So in August, he was still on opioids. The end of September, they stopped giving him opioids. And that's the last X-ray I got. That's all I have.
These cases won't be like that. The last one is a doozy. But, have you had like train wrecks like that in practice? Like, oh yeah. Yeah. Got some Bayonne in there before.
All right.
Yeah. Some new stuff.
Some portion of this, I know their name.
You far to the one. Yeah. Watch down. Straightforward thing would be.
We gave you a little hardwood that we snapped the femur and dropped the other day.
Oh. That's.
Got it.
Oh yeah.
Like not just.
Yeah. Okay. All right. We'll start up, guys. All right. So this first case is a 76-year-old lady. She was transferred to our hospital, had a fall, came with some right knee pain. Baseline, she uses a cane, had previous CR knees done at an outside facility nearly 15 years prior. She's morbidly obese, takes a blood thinner, but overall kind of what you'd expect. These are her x-rays. Jason, you want to tell us what you see? Put her in a splint that, definitely has helped control that. Help her with pain, you're also doing maybe a knee immobilizer. Yeah. Yeah. um, yeah, I think she's neurovascularly intact. Good question, given the amount of displacement that's shorting there. So say Todd, you're on call, working this up. What do you want to get next? And then what are you trying to kind of figure out? CRNA. See. It's good. Yeah. So what would you do, Dr. Cohen? I think she's like 200 pounds or so, but she's like 5 foot. It's morbidly obese. I think her BMI is like over 40. Yeah. You see, when we saw in the CAT scan, we were kind of concerned of these kind of sagittal fractures going down to the prosthesis distally. So we were concerned that it was loose. So we actually did a DFR for this patient. Yeah, yeah, yeah. Well, we like the bone quality is very poor. So once we kind of took out we started taking the femur out, and then we saw like the fracture line kind of went down like under the flange. So we did this DFR, and then she's doing pretty well. Oh no, the videos. Okay. So basically, she's walking around, but it's a huge leg. One thing from the case that I took away from is that it's hard to get the rotation on the femur. So this surgeon likes to use a cable and kind of put the tines like 6 o'clock, like or right opposite the linea aspera to kind of get your bearing. So I thought that was. Yeah. Yep. Yep. for this patient, I think we kept an IVAC on her for, I guess, 3 days while she was here. Transitioned that to a Mepilex, and then she was weight bearing extension for the first couple of weeks, and then she was advanced. She's seen in the office. We just, so that's the first thing we did. We just subperiosteally dissected off the bone, and then it's, so you just want to make sure like your patella is like in the groove, like it's not like too low or too high. Yeah, I think we did one. I can't remember. Our next patient is ET. So she is a 87-year-old lady, presented with left hip pain. She lives by herself, no assisted device. Much remember that big storm that hit our area that caused all the flooding and issues, but basically she'd fallen because her house was kind of flooding. She's trying to clean up and stuff, but she ended up having hip pain, otherwise healthy. She had a history of a left total hip done via posterior approach 2 years prior. These are injury films. So I guess Anna, if you want to kind of say what you think is going on here. You're booking this case for the next day. What would you want to do? Yep, so we took her back and did diacetyl engaging stem. This is like the redapt. This is Smith and Nephew. And we did a trope play on top and cabled it, the medial piece. And then this is where she's at 2 months later, doing fine. It was a, I think, anthology, yeah. No. So there was like on that lateral piece, there's like a non-displaced fracture, and we had so we just wanted to use a choke plate to cover that, but also bring that medial bone closer to our prosthesis there. So these are for those two reasons. It's a Smith and Nephew product. I'm not sure the actual name. So she was like a protected weight bearing with a walker. Do you restrict them? You I guess one of our attendings uses Smith and Nephew, so he'll do them. right, this next patient is a 76-year-old guy who presented with right hip pain. His history is sniffing from metastatic prostate cancer, with no mets to the pelvis, hip, and associated lymph nodes in his lower abdomen. At an outside hospital, he had a pathological right subtrope fracture that was treated with a long nail. He didn't fine after this procedure. This was a year ago, and only started having pain with ambulation 7 days prior to presentation. Did not have any sort of traumatic event or anything like that. He's had chemo and radiation in the past, and was on chemo at the time of this. These are the films that we got for him. Todd, you want to say what's going on? It's just a flush wound. We don't have any previous imaging, but we assume that's where his lesion was. So he had a long nail and implant failure. He fractured right where those recon screws were. Oh yes, it's like a inner choke. So we got a CAT scan just to further, get more information about the pathological fracture. So, what do you think, Dr. Kairos? What would you do here? Yep. So that's what they did. So Next patient is TZ. This is a 63-year-old guy who fell, had some hip pain. He had a seizure associated with this event. He had a history of seizures in the past, but had overall been well controlled. He had 2 seizures in the last 6 years, and now it's kind of when he had his previous fall in 2015. At that time, he had displaced femoral neck, and he actually got a right hip hemi. So this is his second fall. Had another injury. He was using an assistive device. Was COVID positive at the time. Here are his X-rays. John, you want to? So he put in some traction. This is a previous X-ray of what his hip looked like after the hemi. We got a CAT scan to further identify what's going on in his pelvis. Don't take a guess, sir. That's what would be called like anterior column posterior transverse. So yeah, so this is like a dual case. We had a trauma attending come in, they plated, the posterior column, and then after they'd done that, then we kind of assessed, how stable it was, and we realized that there was, superior medial kind of translation. We tried to ream, so it wasn't that stable. At that point, we used a cage, and then from there, cemented in a polar cup, and then did a dual mobility, and then used the same stem he had in his femur. And then this is him at 6 months. And he's doing really well. Yeah, cage and then cement the cup into the cage. I guess your fixation like failure. Yeah. So what we did is like, so we put the cage, we trialed it, and we were satisfied with our plan, So we took the cage out. We actually kind of scored up any sort of residual cartilage in the pelvis, some bone graft, and shoved that in there, and then put the cage back on, screwed it in, hoping that with some sort of bone to incorporate behind it. All right, last patient, RS. So this is a patient who was 70. She's 17 years old. Had usual story for osteoarthritis. She had another hip that was on the opposite side that was complicated by fracture requiring OREF that was treated in an outside hospital. She's obese, has sleep apnea. These are preoperative x-rays. It's demonstrating osteoarthritis of the left hip. She underwent a uncomplicated total hip arthroplasty by an anterior approach. Everything went well. Procedure. Unfortunately, 3 weeks later, she had a fall and had this fracture. She was revised. RAF and changed the stem to a Karai. The drop was stable. Follow up. She done. Persistently, had problems for the next year and a half, requiring multiple PT sessions, walker, problems ambulating, no fevers, chills, or wound problems. Felt that her leg had become shorter, and a year and a half later, after initial, after that revision, this is kind of what her X-ray looked like. Maybe John, what are some things that are a little subsided a little bit? So yeah, so persistent pain, subsidence. Dr. Kairos mentioned the Mayo study. Take someone back to the OR. Within 90 days, the risk of infection is high. Follow up. Flanger labs were elevated. Hip aspiration was done, consistent with infection. So a 2-stage was planned. She got a Prostolac. These are her immediate post-op. At this point, we're treating for a chronic PJI, or cultures were positive P. acnes. Got the ID consult, PIC line, IV antibiotics. Post-op, of course, uncomplicated. She had normalizing inflammatory labs. She had a reaspiration that was negative. These are what her films looked like about 6 weeks after that explant. So she's all teed up for a reimplantation. So during the case, we take out the Prostolac and put the cup in, uncomplicated. When we start on the femur, though, it becomes challenging. She had this history of fracture with this kind of varus bow of her femur. So as we're reaming, we have a posterior lateral perforation. We then convert using reaming over a guide wire to kind of help make sure we're in the canal. We end up trialing. Everything looks good. We start to put down the final implant. We get a perforation distally. So you back everything back out. We use 3 cables, cable it, and then we then go down to proceed to seat the final implant. Once it's seated, we notice that there's a deformity in the distal femur. We look, and there's a fracture distal to the stem. So then we plate this. All the while, this case went from like a straightforward revision to more and more complicated with each of these subsequent events. Patient was converted from spinal anesthesia to general and tracheal. I think she's in some distress as well. So there's kind of a hurry to try to, can't leave a femur fracture. We have to do the best we can. So these are kind of her media post-op films. Patient was kept intubated overnight in the ICU, observed. Overall, she was discharged post-op day 3, kept non-weight bearing. Yeah. Two years ago. So post-op day 20 of this, she comes to the office, persistent drainage in the cervical site. She's talking about she needs multiple dressings per day. Nothing like constitutional about she's septic or anything, but it's presumed, been infected, draining wound, returned to the OR for IND and treatment for acute PJI. Cervical site's opened up and there's copious amount of purulent fluid. This is kind of the sequence of her surgeries, serial washouts, use of wound vacs, IV antibiotics, ID consults were obtained. Initial OR cultures were growing MRSC. At this time, we were able to revise her fixation. just because at the time it was a kind of like an emergent type of situation. We just had to reduce the fracture and get off the table, so we were able to revise her fixation. She was treated with daptomycin, kept non-weight bearing, but she had persistent postoperative seromas that required serial aspirations in the office. So she would come back weekly with decreasing amounts of production of these aspirations. And at 11 weeks, there was no fluid anymore, no aspirations were performed, and she had now an advancement of her weight bearing at this time. These are films at 11 weeks. So 2 weeks later, she comes back, new sharp onset of pain when trying to weight bear, working with PT, starting drainage from the mid thigh, plan for a revision. So these are the films at that time. She had that drainage. So CT scan was obtained, demonstrating, she had a huge collection in her thigh, extending from her hip down to her knee. Some metal like artifact where the plate is obviously and stuff, so it's hard to get a good sense of what's actually going on in the bone in the middle of the thigh, but it's probably not good. So, at this point, Dr. Cohen, like if you're doing like a 2-stage, you're taking everything out, what are you going to leave in there? If maybe the middle of the femur is not viable, how much are you taking? And if she has a knee below it too, that's potentially involved, now. 380. Post-operatively, the oral culture grew at MRSE, on IV antibiotics. And that was transitioned to 4 weeks of PO, 4-week antibiotic holiday, and then hip was reaspirated. Aspiration was negative. They also sent it to like a Mayo Clinic as well for like the PCR, and that was negative. But I think like there's a, I think there was an addendum to their path report or the but so things are going well from the infection standpoint, but she had like an unrelated aortic dissection that required so these are 2 weeks spacer. These are 8 weeks. And then after the dissection's like over and she's cleared, she then undergoes total femur. These are the final. November 23rd. She had a carotid neurectomy, I think, or something, right? Oh.
Yeah, great Friday case.
Couple more here.
More. The explant part. Way hard. Way hard. Right. So smooth. Yeah, you're closing the 4 hours. Yeah.
couple small ones. Steel mesh revision. And just this one.
Oh, that's okay.
Right. Couple cases here. First one's KA. He's an 82-year-old male. He underwent a right total total hip arthroplasty, should say THA, about 20 years ago. Had been doing well until the past few years when he started to experience groin pain with ambulation. Past history of diabetes, cabbage, bilateral total hip replacements. Comes into the office on physical exam. He's walking with an antalgic gait. He has some tenderness to palpation over the trochanter, pain with range of motion of the hip. He's neurovascularly intact. We did get inflammatory labs, which were unremarkable. These are x-rays here today in the office. Anyone want to mention what they see here? Maybe Dan Haddad. May just be a projection there. Yeah, so you pretty much hit it on the head here. So you see eccentrically located head within the socket, kind of indicative of some polywear. You see some osteolysis, mainly around the femoral component. What do you think about the implant, the femoral implant? Do you think it's fixed, or do you think it's like a loose implant? Yeah, so it's a well-fixed implant. You can see here, especially on this AP image, you get some spot welding here, which is kind of a sign that it's a pretty well-fixed implant. He was followed along, for some time, pretty much having the same symptoms, workup for infection, still negative, pretty much optimized for surgery at this point. And then he was, taken back to the operating room, and so basically what we did there, we used a posterior approach, which was his previous approach. We kind of exposed the femur and found that there was extensive circumferential osteolysis present. And what we did was we bone grafted with a metal mesh here, using some femoral heads, fresh frozen femoral heads. The acetabular component was well fixed, so we didn't replace that, just replaced the poly. When we replaced the poly, the metal wired inside. Oh yes. Yeah, so it's like we had to remove the metal clip there. So to remove the clip, yeah. Yep. So we have a clinical photo here, procedure. We use this metal mesh and kind of bone grafted and packed bone graft into this mesh defect. follow-up, he's doing well. Intraoperative cultures were all negative for this patient. Next patient's a little different. 50-year-old male, status post right hip resurfacing arthroplasty was done like 7 years ago by an outside provider. He also had a left hip, which had multiple revisions. Most recently, a year ago for infection. Reports that his left hip was feeling great at that time, but his right hip still causing him pain, having groin pain mainly with ambulation. Walks with an antalgic gait. He has normal good range of motion, but with pain. Not really any significant past medical history. So X-rays here. Anyone want to mention what they see? Maybe Todd? On the right side. Yep. So we have, AP pelvis, an AP and lateral of the hip here, showing resurfacing, hip resurfacing arthroplasty, Birmingham hip replacement, hip resurfacing. Inclination looks good. Cup position looks good. There's no evidence of any fracture or anything like that. But the patient is, symptomatic with groin pain recently after, about 7 years with this prosthesis. Painful metal on metal. Yeah. So in an asymptomatic hip, the number that we look at is like 7. But in a symptomatic hip, anything that's really elevated at all is kind of cause for concern and cause for further investigation. So, in this guy, what we did, we got the inflammatories, White County SRCRP, were all normal. If they had been elevated, we would aspirate. And important thing with aspiration here for metal on metal is a manual diff, because they can be falsely elevated secondary to the metal wear particles. So back to one of the last cases, it would have been good to get a manual diff. I'm not sure if they did that. His chromium and cobalt levels were both, slightly elevated, not in kind of the concerning category really, but, it's still elevated. So an MRI, was obtained here for this guy. Basically what the MRI showed and it was read as is that the patient had extensive pseudotumor, mainly going posteriorly here. So next steps in this guy, he go back to his X-rays here. He has kind of a well-positioned cup. Not too much inclination here. He has MRI evidence of pseudotumor. So next steps for this guy with the symptomatic hip. So revision. So the revision options for these, there's a couple different options. Retention of the acetabular component is one of the options, and you can also replace both components. With retention of the acetabular component, you can revised to a dual mobility implant and not have to touch that, which kind of saves bone. And it's pretty similar to just a primary implant, which is one of the benefits of hip resurfacing. So that's what was done here on the patient. It was a Stryker dual mobility head, 48 millimeter outer diameter, and 28